Good afternoon, everyone. We will be starting our webinar in a couple of minutes. We're just waiting for more attendees to join. Okay, I think we are ready to kick off. Good afternoon to everyone. Welcome to the Center for Vaccine Preventable Diseases Immunization Seminar Series. My name is Shelley Bolton, and I am the Center's director. Before we begin, I wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. For those of you who are joining from elsewhere in Canada, I invite you to reflect on and acknowledge the land on which you live and work. Transparency in research is the key to public trust, so we would like to note that the CVPD is supported by the Dalla School of Public Health at the University of Toronto, which funds infrastructure, faculty, and staff salaries through a mix of operational funding, grant funding, and donor funding, including funds from vaccine manufacturers. We have a robust set of governance processes at the CVPD to ensure that funding sources do not impact the academic freedom of CVPD members. Today, we are very fortunate to have Dr. Giorgia Sulis with us, who will be telling us about her insights on using the Canadian Longitudinal Study on Aging, or the CLSA, to address vaccine-related questions. Giorgia is an assistant professor in the School of Epidemiology and Public Health at the University of Ottawa and an associate scientist in the clinical epidemiology program of the Ottawa Hospital Research Institute, and also a member of the McGill International Tuberculosis Center. Her research interests span infectious disease epidemiology, ranging from prescribing practices, particularly in resource-limited settings, and with an emphasis on the primary level of care, including optimization of knowledge synthesis methods. By integrating a range of methodological approaches, Dr. Sulis seeks to generate new and timely evidence that will inform decision-making and help shape clinical and public health practice changes. So before we begin, a few housekeeping items. Towards the end of the presentation, there's going to be an opportunity to ask questions. So when the presentation is done, we are going to open up the chat pod to start the Q&A period. And at that time, you can feel free to type your questions or comments there. We will do our best to get to as many questions as we can, and we apologize in advance if we run out of time before every question is answered. You may also direct any questions you have after the webinar to our email address, which is cvpd.dlsph@utoronto.ca. Lastly, we recognize the value of reasoned discourse, and this commitment comes with the responsibility to ensure respect for others. So please ensure that any questions or comments for today's speaker is made respectfully and remain in the spirit of positive academic discussion. So with that, Giorgia, it's over to you.
Thank you very much for the introduction and for inviting me to give this seminar. Just give me a second. Hope you can see my slides.
Yep, we can see.
Okay, perfect. Okay. So as Shelley mentioned, I'm joining you today from the University of Ottawa. However, I want to clarify that the work that I'll be talking about was mostly done when I was a postdoctoral researcher at McGill, working with Dr. Nicole Basta, who is the principal investigator of the study I will describe later in the presentation. I have no conflict of interest to declare. And the plan for today is to briefly describe the CLSA, as I'm not sure everyone is familiar with the study, and explain how we can use these results to address vaccine-related research questions. To do so, I will also provide a practical example talking about a study we recently published focusing on pneumococcal vaccine uptake in adults. And I will conclude with some considerations around next steps and specifically research areas pertaining to pneumococcal vaccine uptake in adults that I'm especially interested in, and building on our work using the CLSA. Okay. So the Canadian Longitudinal Study on Aging, or CLSA, is a study supported by CIHR and CFI, and is led by investigators at various Canadian institutions, particularly Perminder Reina from McMaster, Tina Wolfson at McGill, and Susan Kirkland at Dalhousie, in collaboration with a very large team of researchers from across the country. And it's a very large national cohort established in 2011 with the goal of following up participants for up to 20 years. And it's a unique example in Canada. They originally recruited more than 50,000 people who were aged 45 to 85 at the time of enrollment. And participants were included into two parallel cohorts that vary slightly in terms of the sampling strategies and also in terms of data collection approaches. So we have the comprehensive cohort, which includes over 30,000 people and are interviewed by phone and in person, and typically undergo a broader variety of tests. And the tracking cohort includes a bit more than 20,000 people and is only interviewed by phone. Participants are reaccessed every few years. And the vast majority of participants continue to contribute to the various follow-up surveys. So there is a very high retention rate, which is excellent. The main exclusion criteria are for those recruited in 2011, obviously, are being resident in the territories or in the First Nation reserves. So essentially we have participants from 10 Canadian provinces, excluding the territories and the reserves. Those who were living in a long-term care facility at baseline were also excluded. But if someone was admitted to such a facility during follow-up, they remained part of the study. Those unable to speak English or French were also excluded because they are of the impossibility of completing the surveys, and also full-time members of the Army were not part of the cohorts. And this graph provides an overview of the data collection process. So like I said, we have two parallel cohorts, the tracking and the comprehensive cohort. They were recruited both between 2011 and 2013. And that was the time when the baseline surveys was implemented. Participants then were invited to participate in the follow-up one survey, which occurred between 2015 and 2018. And in 2018, they also started follow-up two, which was completed in 2021. At the beginning of the COVID-19 pandemic in 2020, they also included some more additional surveys that were more specific to the pandemic situation. And for example, the COVID-19 questionnaire survey and the COVID-19 seroprevalence study, and later another study focused on brain health and on the consequences of COVID-19 on brain health, which is still ongoing. And in 2021, they also began follow-up 3, which is currently ongoing as well. So you see that there are multiple surveys over time that differ slightly from one another in some ways, but the vast majority of questions are actually asked at each time point. And the data collection process includes questionnaires that look at a variety of factors, and not only sociodemographic factors, but also very detailed medical history, including medication use, previous and current health conditions and healthcare utilization indicators, psychological factors. So there are a lot of questions that pertain more to mental health, lifestyle behaviors, and so forth. And they also undergo a range of physical assessments, such as electrocardiograms, spirometry, cognition tests, and a lot more. So it's a very comprehensive assessment that these individuals undergo very regularly. So it's clear that the CLSA represents a unique data source that allows to study a wide range of health-related questions that are relevant to Canadian adults, and especially to older adults, because actually the vast majority of participants in the CLSA are age 65 or older. And it is the only national cohort of older adults that is available in Canada, and it's a very large one. It provides a high level of details on several aspects. And the other advantage, let's say, is that the CLSA data are accessible to researchers in Canada and elsewhere at a very reasonable cost upon approval of a research proposal. But if anyone is interested in learning more about this process, you can find more information on the CLSA website. So the question that we're actually more interested in today is how we can use the CLSA in vaccine research. So you know that adults, and particularly older adults, are recommended to receive a range of vaccines. The list that I'm providing here is not exhaustive, and just I just identified the vaccines that are most strongly recommended to this population. There are others that are maybe recommended to certain subgroups, but influenza vaccination, pneumococcal vaccination, shingles vaccines, and also COVID-19 vaccines are the most important ones. And all of these can be accessed. The uptake of any of these vaccines can be accessed through the CLSA in various ways. It is especially important if we consider that the national immunization strategy that the government of Canada launched in 2016 includes a few goals pertaining to vaccines in the adult population. And in particular, there's a goal to vaccinate at least 80% of all adults aged 65 or older for influenza annually, and for pneumococcal disease and once in a lifetime. And this has to be achieved by 2025, which is really around the corner. But we are not quite there yet. Actually, we are below target. With respect to influenza vaccination coverage, the situation hasn't changed much in the last few years. You see that the percentage of adults age 65 plus who are annually vaccinated for influenza is stable at around 70%. The green line here represents the goal of 80%. So it's not that far, but it seems that we haven't done much to achieve this goal in the last few years, at least. For pneumococcal vaccination, the situation is more concerning. We're almost stable at around 55%, which is clearly below the target of 80%. But it's not fully clear from these national coverage statistics who is missing and who is less likely to receive a vaccine and why this is happening. So how can you use the CLSA to address these questions? Well, during the baseline surveys, participants were not asked any questions about vaccines. So the initial surveys are not useful in this regard. But during follow-up one, they were asked questions about receipt of influenza vaccine in the previous 12 months and pneumococcal vaccine in the lifetime. And the same question was also asked during follow-up 2. in addition to questions regarding shingles vaccine. So to this, a new addition. Furthermore, in the studies focused on COVID-19, started in 2020, they also included questions on influenza vaccination, so at more time points and before and during the pandemic, and as well as COVID-19 vaccines, such as willingness to receive a vaccine, reasons for getting or not getting vaccinated, and actual vaccine uptake in later surveys. Like all other variables that are included in the CLSA data sets, data pertaining to vaccine uptake are self-reported, which may not be ideal, does come with limitations, and is potentially prone to recall bias or poor recall, especially for those vaccines that are only given once in a lifetime. And someone may not recall having received a vaccine if that happened a long time before. This may be less of a concern for influenza vaccination, considering that the flu shot is typically repeated every year, and so it may be easier to remember that. But it's something that we need to keep in mind, and I'll get back to this point later in the presentation. Unfortunately, it is not possible to link the CLSA data with administrative data sets. Nonetheless, the CLSA remains an excellent opportunity to examine vaccine uptake patterns in relative to a wide range of factors, not only sociodemographic, but also medical history and behavioral factors and so forth. And for certain groups of the population, this is actually the only source of information that we have in the absence of vaccination registries. And for those risk groups for whom we do have national coverage statistics, we can see that the CLSA provides estimates that are very consistent with national statistics, which is good news. So now I will provide a practical example of a study that we've done using the CLSA. We recently conducted a few studies, some of which have already been published using the CLSA data and looking at various vaccines that are recommended to adults. We've looked at influenza vaccination both before and during the COVID-19 pandemic. We've looked at willingness to receive the COVID-19 vaccines. And we've looked at pneumococcal vaccination, as I mentioned previously. And this is the study I will focus on. I will touch the key points of this work. If you're interested in learning more, you can find the full text by using this QR code. The objectives of this work were to estimate self-reported pneumococcal vaccine uptake and differences in uptake among Canadian adults eligible to be vaccinated. And essentially, we focused on two specific subgroups: adults aged 65 plus, and those younger than 65 who had at least one underlying conditions. These are not the only ones who are eligible to receive a pneumococcal vaccines, but this is what we could do using the CLSA. And in terms of underlying medical conditions, we considered a range of conditions that are known to increase the risk of hospitalization and death due to invasive pneumococcal disease. That could be reasonably well identified using the CLSA. We also wanted to identify factors associated with pneumococcal non-vaccination, so identify those who are less likely to receive a vaccine, and access and frequency and determinants of missed opportunities for vaccination. I'll get back to the concept of missed opportunity and how this was defined for the purpose of the study. Like I mentioned at the beginning of this presentation, the CLSA originally included more than 50,000 participants. These are those who were recruited during the baseline surveys in 2011, 2013. But like I said, it was only during the follow-up one survey that participants were asked questions regarding vaccine uptake. So we focused on those who responded to follow-up one, represent almost 95% of those recruited at baseline. And among those who responded to follow-up one survey, we identified those potentially eligible to receive a vaccine based on current recommendations. So again, those aged 65 and older, and those younger than 65 who had underlying conditions. Only a very small number of participants aged 65 or older were excluded because they did not respond to the question on pneumococcal vaccine uptake, but very, very small numbers, so unlikely to have had any impact on our findings. And we ended up with more than 22,000 participants aged 65 plus, and almost 11,000 younger than 65 and who had underlying conditions. We focused on two types of outcomes: lack of pneumococcal vaccination, which was considered as binary, vaccinated versus non-vaccinated, again, self-reported. And the other outcome of interest was having missed an opportunity for pneumococcal vaccination, and more on this in a bit. And we considered a range of sociodemographic characteristics such as age, sex at birth, race, ethnicity, education level, annual household income level, province of residence, urbanicity of residence, and so forth. We considered a range of chronic conditions that are known to increase the likelihood of severe outcomes from invasive pneumococcal disease. And we considered whether participants had had any contact with a family doctor in the previous year, and whether they had received a flu shot in the previous year. These two variables were important to define missed opportunities, as I will explain in a bit. We analyzed data separately for the two subpopulations of interest. And first, we conducted descriptive analysis to examine changes, to examine pneumococcal vaccine uptake and differences in uptake across subgroups defined by covariates of interest. And we used multiple logistic regression models to examine associations between lack of pneumococcal vaccination and those covariates. Unfortunately, we couldn't apply any sampling weights, because sampling weights for participants in the follow-up one survey have not been developed. But we followed the CLSA guidelines on analysis by always adjusting our estimates for certain factors such as province of residence and sex, which are essential to sort of find some balance and account for the different sampling distribution across the country. And we conduct a similar analysis to evaluate missed opportunities for vaccination. Given the limitations of having self-reported vaccine uptake information, we conducted sensitivity analysis and simulated multiple scenarios, assuming different levels of sensitivity and specificity of pneumococcal vaccine uptake reporting. Our findings didn't change based on this sensitivity analysis, but it is important to consider the potential for misclassification in pneumococcal vaccination status. So let's look at some key findings. With respect to adults aged 65 or older, we found that 54.2% reported having received a pneumococcal vaccine, which is consistent with national coverage levels for this population. We see that, again, we're definitely below the target of vaccinating 80% of those belonging to this group. But who is more likely to be non-vaccinated? Well, males more than females, and those who self-identified as non-white versus white participants. those residing in most of the Atlantic provinces, except for Nova Scotia, compared to those living in Ontario, which was set as reference for a convention, and those living in rural versus urban areas. The strength of this association was not huge for most of these factors, but I want to highlight the important heterogeneity based on the province of residence. And you see, for example, that participants residing in Newfoundland were more than twice as likely to be non-vaccinated compared to those living in Ontario. And there may be various reasons for this, including the fact that in Atlantic provinces, pneumococcal vaccines are not offered at pharmacies. So this may pose some issues in terms of access to this vaccine. There are factors that favor vaccine uptake. For example, the likelihood of pneumococcal vaccine uptake in this group increases with age, which is intuitive. It's kind of expected. Increases also with increase in income. It's higher for those residing in Manitoba, Saskatchewan, and Quebec. And it's also higher for those living for those having at least one underlying chronic conditions. So sicker individuals are more likely to be vaccinated, also quite expected. But this factor that most strongly favors pneumococcal vaccine uptake is prior receipt of influenza vaccines. This is in line with other findings from other studies we've done using the CLSA, where we found that those who consistently get vaccinated and are more likely to engage regularly with immunization services are also more likely to receive other vaccines. And also those who had a contact with a family doctor in the past 12 months were more likely to receive a pneumococcal vaccine. For adults younger than 65 who had at least one underlying chronic condition, the situation is a lot more concerning. Only less than 20% reported having received a pneumococcal vaccine despite being eligible. We don't have any national coverage statistics to compare because this is not available. But there is also less variability in this population in terms of sociodemographic profiles, perhaps just because the vast majority is non-vaccinated. But we found something strange that I really can't explain, which is that people with higher income were actually less likely to be vaccinated compared to those with lower income. For example, those with an income of above $100,000 or $150,000 per year were 2 to 3 times more likely to be non-vaccinated compared to those within the lowest income level. And the other factor that was associated with lower likelihood of being vaccinated, the higher likelihood of being non-vaccinated, was residents in Newfoundland, but not in other Atlantic provinces, as observed with older adults. Again, residents in Newfoundland were found to be 2 times more likely to be non-vaccinated. And likelihood of vaccination increases with age. And again, a receipt of influenza vaccine and having had a contact with a family doctor are most strongly associated with increased likelihood of vaccination. And this brings me to the problem of missed opportunities. The World Health Organization defines a missed opportunity for vaccination as any contact with health services by an individual who is eligible to receive a certain vaccine, which does not result in the person receiving one or more doses of the vaccine for which they are eligible. We know that not all types of health services are able to provide vaccination for a number of reasons. Sometimes there are contraindications to receive a vaccine. And for example, if you're visiting your doctor because you have an acute condition like fever or cough or something like that, you can't receive a vaccine at that point in time. So this definition is a broad one that needs to be refined. And for the purpose of the study, we consider two types of missed opportunities. Receipt of influenza vaccine, this is actually the best opportunity for someone to receive another vaccine for which they are eligible. We know that if someone is receiving a flu shot, certainly they have no contraindications to receive another vaccine at that point in time. And this vaccine could be safely administered together. We also considered another type of missed opportunity, which is having had a contact with a family doctor. But again, like I said, it is possible that someone visits a family doctor for something that prevents them from receiving a vaccine at that point in time. Still, this can be an opportunity to talk about prevention, to schedule a vaccine for some other time. So it can still be considered a missed opportunity in some way. So for both populations of interest that we looked at, so older adults and adults with underlying conditions, we found that after adjusting for all of sociodemographic factors as done in all our other analysis in our work, we found that males were more likely than females to miss an opportunity for vaccination. And the same happened to residents in the Atlantic provinces, again, versus those living in Ontario. And this was true for both types of missed opportunities. But how common is this? Actually, very, very common. If we look at those who reported having received a flu shot in the previous 12 months, we find that more than 30% of adults age 65 plus missed an opportunity to receive a pneumococcal vaccine, and the percentage increased to more than 70% among adults with younger than 65 with underlying chronic condition. If we look at those who visited the family doctor in the previous 12 months, we found that 45% of adults age 65 plus missed an opportunity for vaccination, and more than 80% of adults younger than 65 with underlying condition missed an opportunity for vaccination, actually the vast majority. There are some limitations that I want to mention, and some limitations in the study that are mostly related to the nature of the data that we used. Data were collected pre-pandemic, because all this work is focused on data collected during the follow-up 1 survey. At the time of the study, data from follow-up 2 were not yet available. And so it is totally possible that something changed in the meantime, especially considering the impact that COVID-19 had had not only on routine immunization services, but also on vaccine hesitancy, on confidence in vaccines in general. And we could only use cross-sectional data, so there is no way with the study to look at time trends and how different factors affecting lack of pneumococcal vaccination changed over time. Again, vaccination status is self-reported in the CLSA like all other variables, but we conducted sensitivity analysis to investigate the potential impact of this self-reporting. We had no information on the reasons why people did or did not receive a pneumococcal vaccine. We can make hypotheses based on the patterns we observed. For example, the differences between provinces may be due to how and where pneumococcal vaccines are offered and are accessible to eligible individuals. But we don't know exactly what barriers, what factors led participants to receive or not receive the vaccine. Nonetheless, this work has the strength of utilizing the largest cohort of adults in Canada, which is an extremely good opportunity given the lack of vaccination registries. There is, at least in the Canadian context, there are no other sources of vaccine uptake information for this population, especially for adults younger than 65. who have underlying conditions, but also for older adults. At least we were able to look at uptake estimates in various subgroups, for example, in females versus males, or in people living in different areas of the country, in rural versus urban areas, and so forth. And we had participants from 10 provinces, so a snapshot of what's going on across the country. Main takeaways from the studies are obviously that the uptake remains too low and is below expectations for at-risk individuals. And although we cannot comment on the reasons why this happened, it is very likely that awareness about pneumococcal vaccines in this group is low. And this may be contributing to the low levels of uptake. So if someone is not aware of these vaccines and their potential benefits, both direct and indirect, is less likely to receive the vaccine. Again, we found substantial heterogeneity across provinces, which provides food for thought regarding how vaccination programs are implemented. And we found a concerningly high level of missed opportunities, which requires efforts to solve the problem. The missed opportunities represent really show that we need and can do better, and especially for those who are receiving other vaccines for which they are eligible. And before heading to some conclusions around the next steps in research in this area, I just want to acknowledge the contribution of all collaborators that were involved in this work at McGill, at the University of Calgary, at LAUSI. And I also want to thank the CLSA team for making this resource available to all researchers, and to CLSA participants for taking the time to complete the surveys and allowing researchers to use this information to address a range of questions. And now I just want to spend a few words on what really needs to be done next. There are a lot of things, then are a lot of research areas that require more investigation, starting from the development of pneumococcal vaccines that are more effective, that provide a broader coverage in terms of strains, in terms of serotypes, of pneumococcal serotypes that can be prevented, in terms of duration of protection. This is not. This is obvious, and it's also worth mentioning that we recently had 2 new pneumococcal vaccines approved in Canada earlier this year. So this is good news. There is a lot more to do in this area, but I want to focus on another aspects that is more about the vaccines that we already have. It's definitely important to continue monitoring changes in pneumococcal vaccine uptake. As I mentioned, our work was focused on pre-pandemic data, but it is important to see what happened during the pandemic, what's happening now. And we are working on this. The follow-up to data were recently released, and we are now analyzing this data to see what happened in the meantime, and whether missed opportunities are so frequent as they used to be a few years ago. These low levels of pneumococcal vaccine uptake also show the need to develop and test strategies to improve awareness and uptake of pneumococcal vaccines in higher risk groups. And this is another area that I'm personally very interested in. I'm currently leading a project within the Canadian Immunization Research Network to assess the barriers to pneumococcal vaccination to increase vaccine uptake among older adults. And so we want to develop and test an educational intervention targeting this group. And I take this opportunity to make a small announcement. I'm actually looking for a research associate or a postdoctoral researcher who is interested in collaborating on this work. If you want to learn more, you can find the details using this QR code. And there are also there's also another point that I'd like to highlight. Pneumococcal vaccines, like vaccines in general, are increasingly looked at as potential tools in the fight against antimicrobial resistance. Vaccines can be a way to not only to reduce the burden of the conditions that they are meant to prevent, but can also be a way to reduce the consumption of antibiotics and ultimately reduce the emergence and spread of resistance. With the growing growing emergence of resistant bacteria, including pneumococcal disease due to resistant bacteria, prevention represents an important tool because we really need to save antibiotics, and prevention is also a way to avoid cases that may be hard to treat. However, what's the impact, how much the pneumococcal vaccination impacts antibiotic utilization and the emergence of resistance remains debatable, and it's not completely clear, especially in population groups like older adults. The little evidence that is currently available is mostly comes from studies done in infants and children. There is very little evidence from older adults, and it's mostly unclear and suggests high variability between settings. So this is an area of research that needs to be expanded more. And this brings me to the importance of having vaccination records available, because this type of research really needs the availability of vaccination registries. And with data sources like the CLSA, which are great, we can do only so much. So vaccination records and improving recording and reporting of vaccination status is really important to address a range of research questions like this one. And with this, I would like to thank you all for the attention. I'm happy to take any questions.
Thank you very, very much for your really interesting presentation. Now we have some time to answer questions, so you can use the chat function to submit questions or comments for Giorgia, and we will do our best to get to everyone's questions in the time that we have left. So the first question that I see is about the representativeness of the participants within their provinces. And it was also a question that I had. What is the representative ness like in general? So geographically, in terms of racialized individuals, newcomers, sociodemographics like income, are you able to comment on when you compare this to the general population or to census data, how things look?
In general, so the CLSA, to my knowledge, is a good representation of the national population across provinces. But there are some studies that have shown that CLSA participants are generally a little bit more educated than the average population of the same age. So this is the main difference. I think that in terms of racialized communities, I'm not sure how representative that is, just because they excluded participants who didn't speak English or French. So it is possible that those who were not able to respond to the questionnaires were excluded. And so, representation might not be ideal in that sense.
I think that makes a lot of sense.
I would also mention that the CLSA, they allow a proxy responder. So it's for participants who are not able to respond to the service themselves. There can be a caregiver, someone in the family who can respond on their behalf. This may allow those who do not speak English or French to participate, I guess, but honestly, I'm not sure. I'm not one of the CLSA investigators, so I don't want to provide incorrect information.
I think what you say makes a lot of sense, and I think that the coverage estimates that you've presented are quite low. And so even if they're not super accurate due to a lack of representativeness, I think it's clear that we're still not where we need to be according to the targets. Your next question is, what are your thoughts on the income-related findings and reduced vaccine uptake?
So I guess you're referring to adults younger than 65 who had underlying chronic conditions. Yeah, this is a really surprising finding. Honestly, I don't have an explanation for that. I'm not even sure. There is certainly confounding in there. There are certainly factors that we're not able to access because this is in contrast with most evidence regarding vaccine uptake, not only for pneumococcal vaccines, but in general. We typically see an increase in vaccine uptake with increased income due to better access, but also due to higher education and better knowledge about health and prevention. It is possible, but this is just an hypothesis, not based on any data. It is possible that those with higher income are healthier and maybe do not perceive this vaccine as being necessary for them. But I also want to mention that the group we looked at is a group of people who had underlying conditions that increase the risk of pneumococcal disease. And so this is not a very healthy group of people in general. Honestly, I have no idea.
I think it's an interesting finding. It's also possible that the potential issues on representativeness are being reflected, but it's hard to know.
Yeah.
So the next question is about missed opportunities. And one of the missed opportunities that you identified was contact with family doctors. And we also saw that, or we know rather, that many residents of rural communities don't have access to family doctors, at least in Ontario and I think in other provinces too. And they're one of the populations that you identified as less likely to be vaccinated. So wondering whether you have any reflections on whether these two facts may be related.
So based on how the questions in the CLSA surveys were framed, I want to point out that they didn't ask, do you have a family doctor? This is not a question we looked at. It's whether they had a contact with a family doctor, not necessarily their own doctor. So it could be a walk-in clinic with a family doctor. It's just the fact that they sought care.
Okay, that's really
in that type of service. They also had questions about hospitalizations, but we didn't consider those because we didn't think that they could be considered a good type of missed opportunities for, given it's unlikely that someone received the vaccine, for example, when they visit emergency room or that sorts of thing, especially given the situation that we are in now in Canada in general. But visiting the family doctor, regardless of whether they have a family doctor, they have an assigned doctor or not, is a missed opportunity. However, I agree with the fact that if someone doesn't have an assigned doctor, that may be a reason for missing the opportunity. Because if it's not your doctor and there is no follow-up, maybe there are less let's say, incentivized to offer the vaccine or to schedule something at some other point in time, just because this is not their patient. Indeed, this is something that needs to be investigated further. In fact, one of the other study that we're currently starting, looking at barriers to vaccine uptake, will look at this kind of factors and what type of barriers are preventing people from getting vaccinated, including whether they have a family doctor or how far they are from health facilities. This is especially important for those living in more remote areas rather than those living in large cities, for sure.
Yeah, that makes a lot of sense. The next question is, what role could vaccine fatigue have played in the lower pneumococcal vaccination rates, particularly during the height of COVID-19 vaccine promotion?
I'll tell you next year when we have the results of the follow-up 2 survey.
Can you hypothesize?
Yeah. Sorry?
Can you hypothesize from like other things that you know?
Well, I think that for certain population groups, probably it did play the role. It did play a role, and because for vaccines that are not perceived as essential, I guess that people may be less likely to be vaccinated. For pneumococcal vaccines, I think the biggest problem is the lack of awareness about this vaccine. Most people don't even know they exist and or why they can be important. And the other factor is that even health providers sometimes are the first who do not offer they do not offer this vaccine in the first place, and because they have low confidence in the effectiveness of these vaccines, which is why it will be important to see what happens with the newly approved vaccines. In February, the NACI changed the recommendations and included PCV20, the new conjugate vaccines, among recommended vaccines for older adults. This is likely to have a higher effectiveness. So let's see if health providers are more likely to offer this vaccine instead of previous ones that are known to have a suboptimal effectiveness. So there are a range of factors to consider, not just vaccine fatigue or other issues related to the pandemic. It's more complex than that, in my opinion.
Okay. Thank you. The questions are still pouring in. Okay, we have time so there's one comment in response to this discussion that I think everyone can see about the fact that family physicians were seeing far fewer patients and public health programs were focused on COVID. And yeah, it was potentially an access question as opposed to a patient decision question. Okay, so one more question. I love all the thoughtful discussion. It's Shazza Fadl, and she is not sure whether you showed provincial heterogeneity among missed opportunities you measured specifically for influenza vaccine. Do you have those data, and can you tell us if there was variability among provinces?
So in terms of variability among provinces, the main findings from the study was that Atlantic provinces in general have the biggest problems. They show the lowest levels of uptake across all groups, regardless of age, sex, race, income level, anything. And they also show the highest levels of missed opportunities. We try to understand what could be driving these differences. and looked at how pneumococcal vaccination programs are organized in different provinces. It's not easy to do this type of assessment because the information is hard to retrieve. We looked at the year in which the programs were launched, and across provinces, I mean, this program started many years ago, so I don't think it's related to the recency of implementation, nothing like that, but rather to where these vaccines are offered. And in my opinion, one of the most important factors is that pneumococcal vaccines are not available at pharmacies, which is where people typically get the flu shot. And that's the main type of missed opportunity, in fact. If someone is receiving the flu shot at a pharmacy, but there is no way for them to also receive a pneumococcal vaccine at the same time, and receiving a pneumococcal vaccine is more complicated because they have to book an appointment at a vaccination clinic or some other thing. They may not be doing so. Maybe they don't even know they need to do that. In other provinces, pneumococcal vaccines are increasingly available at pharmacies, maybe not in all pharmacies, but in many of them. And they are still provided for free because it's a publicly funded program. It's more complicated for adults younger than 65 who have underlying condition, though, because for them, also in provinces where pneumococcal vaccines are available at pharmacies, the vaccine may not be covered by the health insurance, the public health insurance, if they get the vaccine at pharmacies for some reason. So there are certainly accessibility aspects to improve.
Yeah, and such heterogeneity between jurisdictions.
Yeah.
Okay, well, thank you very much for speaking today and for all your great answers to our many questions. And thank you very much to everyone who joined the webinar this afternoon. We're always striving to improve our webinars and events, so we'll be sending out an evaluation survey through the chat pod. I see it right now. It's only a few questions. It'll take you less than 5 minutes to fill out, but it's incredibly helpful feedback for us. To register for our upcoming events and to keep up with what's happening in the immunization world and at the center, please make sure to sign up for our monthly digest, which is also in the chat pod. Thank you to all of you for joining today, and hope to see you in the future.